Good morning, everybody. I'm conscious I'm the fourth speaker of four. You must be desperate to be fidgeting and moving a little bit. I hope what I'm going to say is going to build on, actually, the information that we've already talked about so far this morning. You've seen an awful lot of information in the space of an hour. Some of what I say will hopefully consolidate some of that a little bit. So my name is Crispe. I work for a not-for-profit organisation called Health Enterprise East. We are based in Cambridge, and we are an NHS innovation hub. So a bit like Ravi said earlier, the NHS is a big brand, lots of things sit underneath it, and then innovation hubs are one of those things. What I was asked to talk about this morning was understanding the care pathway. Now, of course, you could interpret that in about a million ways, but my background is an economist, so I've interpreted in that way, and I work with lots of small medtech companies in the UK looking at the economics of their innovations, so that's the perspective that I'm taking. So we've had really interesting talks from a regulatory perspective, from a research perspective, from a provider perspective, and I'm going to talk a little bit more from the medtech perspective in the UK. So what's happening? Well, it's a pretty large medical equipment market, 6th largest in the world, and it's growing. So we've had this desperate recession and downturn in the last few years, but despite that, it's growing. It's currently valued at just under £6 billion a year, so it's sizable. A lot of the market is supplied by imports, and Chris was talking about the difficulties in securing the supply chain and making sure that that's robust. So that's quite a high number that you can see there. So there are plenty of opportunities. The number of medtech companies in the UK is growing, and more people are being employed in medtech in the UK. And the NHS, this big thing we keep talking about, accounts for about 85% of the total market. So that really is the kind of dominant customer. So a little bit about this NHS. Now, the disadvantage of being fourth out of four is that you've seen some of these numbers already. But maybe second time around, they might go in a bit more. So it's an amazing thing, the NHS. It's very complex. It spends a lot of money. It employs a lot of people. It's structurally complex, and that is an issue for medtech companies, and it's an issue for medtech companies in the UK, as well as everybody else coming from the rest of the world. You can see there, those are the figures just for England, actually. So we have about 8,500 primary care practices. When I say primary care, I mean family doctors. We have about 250 plus large teaching hospital trusts, but many of them, as Chris has already given a lovely example of, have more than one site. So it is quite complicated. And that structural complication is important for companies to understand a little bit, because different bits of the NHS operate in different ways. So Chris has talked about how the funding flows down to his hospital. For those 8,500 family care practitioners, they are effectively small independent businesses. They work under contract to the NHS. So it's another part of that NHS brand with lots of things going on underneath. And for medtech companies, that can be really difficult because the cost of sales for 8,500 small businesses just for England is a bit frightening. So it's important to understand what their motivations might be if you've got a product that is aimed at that sector of the market. I think the thing that people have sort of alluded to this morning, they've talked about cost effectiveness and cost efficiency. I'm an economist, I like those things. But, you know, we're not alone in this. We are projecting a big funding problem. Whether it will actually hit the £30 billion a year mark by 2020, well, who knows? But I think it's very clear to see, if you look at the performance, particularly of hospital finances in the UK, which is a bit unfair to pick on the hospitals, but they're the most visible, they are starting to deteriorate. Their finances are getting tougher, and that is a consequence of reduced public sector investment as a consequence of the financial crash. So whether it'll be that bad by 2020, I don't know, I hope not. But there is a real environment of economic and financial pressure. And I think as potential sellers to the NHS in the UK, it's worth you understanding that context. Now, Chris has already talked about this, which means that I don't have to in any great detail. So he's talked beautifully about the green box, which is the clinical commissioning groups. Everything underneath the blue line is basically a provider, and everything above the blue dotted line is either a commissioning organisation, so they are responsible for contracting, driving care, setting standards, having those local negotiations, and they're also responsible for performance management of organisations. And everything below the line is a provider, so that might be mental health, it might be community healthcare services, it might be an acute trust, and primary care sit there. And I think the reason it's helpful to show you this again is that you can see that it's fragmented and you can see that it's complex. And I think in some ways it's getting more fragmented and complex. So Chris has talked about some changes that we had in 2013 that meant more commissioners, and those changes are still evolving. Different parts of the system are responsible for making decisions in different provider areas. So at the moment, you can see those purple blobs of NHS England and local area teams. They currently contract for primary care, although they're starting to have some discussions about whether that's the right way of doing it. And the green blob contract for basically all the other types of NHS trusts. It's worth knowing that commissioning is trying to be more outcomes driven. And we've talked a lot about evidence this morning, and I think that's only going to get more important. Patient engagement and the patient's assessment of their care is also becoming much more important, and that's another thing that might be interesting for you to think about. So, we've seen from the previous slide that the environment is not that easy to navigate. So why does the clinical care pathway actually matter so much? Well, I would argue that it matters because it helps you to understand actually who your customer is in this really fragmented space. So we've talked a bit about this. Different organisations commission different parts of the care pathway. And within the overall commissioning framework, and Chris has talked about this, we had a lovely question about this just before I stood up, decisions about purchasing specific equipment or tests may lead to costs and savings for different organisations. Effectively, the decision to invest in the equipment might save the NHS money, might be better for patients, but not actually save the investing organisation anything. And that's the slide that we started off very first thing this morning said something about the financial payments and incentives are not always aligned to drive innovation. And that is a lovely example of that, which I will give you a case study of in a minute, try and make it a bit more real. So understanding your care pathway from a clinical perspective therefore helps you understand how to pitch your product. Now, how can you do this? Now, I'm sorry about this slide. It's a complicated slide, but I thought it was worth sharing with you because there is quite a lot of public data. It mainly relates only to England, not the whole of the UK, although if the Scots decide to go their own way next week, that will be a bigger proportion of the total. But it's really useful. And when I talk to medtech companies in the UK, I'm working with 15 medtech companies at the moment, most of them didn't know about this. So please don't feel like you are in any way the minority or badly informed. This is not widely known. But what these are potential tools that you can use to start thinking about your pathway and the impact of your pathway at a high level. I'm not saying this is the detailed work. Nick's probably sitting here thinking, this wouldn't be, there's another level of detail, but it's a starting point. We've talked already this morning about clinical insight, and you just can't beat it, and I don't think you can ever have too much of it. And I think that's really important. And I talk to quite a lot of companies who've got a brilliant idea, and they've spoken to one doctor, and the doctor liked the idea, and then they go off and they go and develop for a long time. And you just need more than that. You need a range of opinions, and you need them early. You cannot have them too soon. I think that's really important. Building on your clinical insight, there is some information which might also be helpful. And these are some sources of that information for the UK. I'll run through them quickly. I'm really happy to take questions or talk to you more about them in the break. So the national tariff is a price system. So everything that hospitals do has a price attached to it. Outpatient activity, some diagnostics, inpatient spells, we call them, episodes of care, have a price. And those prices are totally public. You can see them. And I'll give you a case study, an example in a minute, which uses those prices. Reference costs are submitted by hospitals every year, and they say what doing that activity has actually cost them. So the price might be one thing, the price might be £100. But you can look at the reference costs and you can see, well, actually the hospitals it's saying it's costing them £200 to do that thing. And that might give you an indication of, is this an area of the market where people are making money, or is it an area of the market where money is tight? Is it an area of the market where my innovation might make a difference to that? That's important. Hospital episode statistics, these are a little bit complicated, but basically they give you volumes. So if you want to know how many colonoscopies we did in adults in England 2 years ago, the hospital episode statistics can tell you, and that can help you shape the size of your potential market, possibly. There's a performance framework, which the NHS loves. Nick was quite funny when he said earlier, we haven't got a punishment group yet. I think the rest of the NHS does. Hospitals get fined for not doing lots of things, and those fines can be millions of pounds. This isn't likely going to be your core business, but sometimes the ability of an innovation to release capacity or make a change in a pathway, while it might not release cost, it might help hospitals deal more effectively with something else which is causing them a problem. And so having a little bit of awareness of that can sometimes be helpful. Nice technology appraisals, clinical guidelines, etc. Nick has talked about beautifully. There is a huge amount of information on the NICE website. There are lots of costing reports. There are lots of backup information that they provide. It's all publicly available. And so there might not be your innovation, but there might be a similar innovation in a similar field. And you could look at the costing report and see, well, how have they thought about this? How should we be thinking about this? How should we be building the case? All this stuff is publicly available. The UK government website, www.gov.uk, the NICE website. You can send them queries. It's useful stuff, potentially, for understanding your market. So how might you use these tools? Well, this is a real example from a company that I'm working with at the moment. They are at proof of concept phase, very, 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 very early days. And they are a company which is being funded by something called the Small Business Research Initiative in healthcare in the UK, which is, again, I think, an interesting structural thing, actually, that we might want to talk about, and I'm happy to talk about that more. So this example, this company have got a non-invasive test which potentially has the power to detect and exclude colon cancer, and possibly other cancers also, given time. So it's quite a big deal, potentially. And we've been doing some very early work to think about what that might mean. So the current pathway you can see in blue on the left-hand side. The family doctor suspects colon cancer, refers to the hospital for advice, using some sort of guideline, which will probably be based on the NICE guideline for this, and all of those are public as well. Patient is typically seen as an outpatient at the hospital, and then they might be managed in a number of ways. This is obviously extremely simplified, but bear with me. So I've said that they might be discharged from the hospital, they're fine. They might go on to have an endoscopy, or they might go on to some sort of other management. And then for the ones that have an endoscopy, they may then be discharged. They may go on to a pattern of repeat surveillance endoscopies. They may proceed to treatment. Lots of other things might happen, but it's a simple example. The green box, can you read that at the back? Maybe not, is activity. So using the hospital episode statistics that we talked about earlier, and using some estimates that we've derived from other things, you can see that there were about 386,000 hospital appointments related to suspected colon cancer in the year 2012-13. And we can see that there were 261,000 colonoscopies performed on adults over the age of 18 in the same year, plus or minus biopsy. Now, all of those things have a price, so the yellow boxes are starting to talk about money. From the national tariff, you can detect that, I've used a gastroenterology appointment for this example. The national tariff for that appointment is £178. So every single appointment new appointment cost £178. And that's a total of 68.7 million that we spent on those appointments. For colonoscopy, There's a couple of tariffs. I've used a weighted average between ones with or without a biopsy, £487 every time. So if you multiply that through, you get another 127 million. So the total cost, 196 million, of the first couple of steps of that simplified pathway. So what would change if this little company can make its brilliant innovation work? GP would suspect colon cancer, and at that point, they might order this test. It could be done in primary care. And then they might refer on to secondary care, but you could make an assumption that fewer people would be referred on to secondary care. Some would still go, even if they haven't got cancer. GP might want advice, that's fine. But perhaps 20% wouldn't. And that's a key number where you'd need the opinion of as many expert clinicians in the field as you could possibly get. This is a simplified example. And you might then assume that if 20% fewer people are going to hospital at all, 20% fewer endoscopies might be done. And again, you need to test that assumption to death, really. And you can do the same maths. So we've built in here a cost of test of 30 quid. Company doesn't really know at the moment. That's its best guess, but it's you've got to start from somewhere. So if everybody was tested before they went to hospital, that would cost the health service just over £11.5 million. But we'd have fewer outpatient appointments and we'd have fewer endoscopies. So the total care pathway cost is now 169 million. It saves 27 million a year, including the cost of the test. Now that would be a major change. And clearly, colonoscopy is a very good test for colon cancer in terms of being specific and sensitive. You're not going to remove a proven test from a pathway without massive amounts of evidence. And really, this would be probably something that, Nick, you would think about at a national level, because it would be a guidance issue, wouldn't it? You'd be looking to make a very high-level change. But that £27 million, who gets it? Who's the customer? Well, tests ordered by family doctors are paid for, generally, by their local clinical commissioning group. So the CCG would have to fund that additional test cost, and that fits in nicely with what Chris was saying about they're starting to have conversations with their commissioners about, you need to pay for this. The hospital, not so good news for you, Chris, would see a reduction in outpatient endoscopy activity. So they would get paid less because the tariff is essentially cost and volume. Hospitals are paid by the clinical commissioning group, so those savings are kind of accruing at the level of the commissioner. And so the commissioner could fund the test, but still have some savings because it's not paying the hospital to do quite so much work. That's the theory. In practice, lots of different things happen. Hospitals either might have to reduce their costs or their capacity to meet the fact that their income has gone down, or they might actually need to use that capacity. They might have a waiting list. They get fined for having a waiting list. So they might actually want that extra capacity because it would help them deal with a different problem. Or actually, we know that the incidence of many of these diseases is rising and is likely to continue to rise, so they might want that extra capacity as a buffer to help them deal with genuine increasing demand, even with a new care pathway. So it might save some actual cash for the commissioner, or it might provide much needed capacity in the system, which helps patients. And the actual scenario is going to vary kind of case by case, really. So I hope that helps a little bit. So that's a real example, very first line, top level, but you can use those numbers. They're out there, they're public. You can start to think about them. That's a little bit about more what we do, and I'm really happy to take any questions. Sorry, I'm trying to finish.
No, it's okay. Ted has been mad at me because I've been letting you talk so much, but it's okay. I think it was very interesting, but we are late, so I will just have one question from the audience, and I will be silent. If there is any questions, Rana? Oh, you all want coffee?
I want coffee. It's fine.
Is it okay if we have 20 minutes, or what? When do we start?
We need to start sharp at 11.
We start again at 11. See you guys then.